afternoon, everybody. The topic for discussion today is dyslipidemia, flashback and vision ahead. And I, Dr. Professor PC Manoria, Director, Manoria Heart and Critical Care Hospital, Bhopal. All of us know dyslipidemia is the most common major modifiable risk factor for atherosclerotic cardiovascular disease. And statins are an integral part of lipid management. We've been using them for the last 33 years, and the king statins cannot be replaced. But during the last couple of years, there has been a sea change in lipid management. Evolocumab and alirocumab, which are two fully humanized monoclonal antibodies, were approved in 2015, and with this, PCSK9 has become a validated target after the two landmark trials, the Fourier and the Odyssey. Both these molecules have evoked a new concept of super low LDL, that is LDL between 20 to 50. And interestingly, this has shown incremental benefit with incredible safety. All of us remember, in the statin era, the dicta was LDL, lower is better, and the LDL which was targeted in the statin era was 70. But in the PCSK9 era, the dicta is super low LDL, still better than lower LDL, and the current target for LDL in the very high risk patient is 55. And the conventional target of the statin era, LDL less than 70 for the very high risk patient, has become obsolete. Besides these two monoclonal antibodies, we have small interfering RNA, which inhibits the synthesis of PCSK9, and the most peculiar feature of this molecule is a single injection of 300 milligrams decreases LDL by 50%, and this remains there for 6 months. It is emerging as an important competitor to evolocumab and alirocumab, the monoclonal antibodies against PCSK9. PCSK9 vaccine is a new therapeutic innovation. A single vaccine decreases LDL by 50%, and this remains there for 1 year. The human studies are ongoing, and if this comes out to be positive, a booster dose every year will be the new modality for minimizing atherosclerotic cardiovascular disease. Now, this shows the evolution of lipid guidelines for the last 32 years, ever since ATP1 came into existence in 1988 till 88, 2020. All these lipid guidelines, LDL cholesterol is the primary target, and this is the main lipoprotein which is responsible for atherosclerosis. Non-HDL cholesterol is the secondary target. Some of the professional bodies, as you can see on the slide, have recommended non-HDL as the preferred target, but it does not make any difference whether you target LDL first and then non-HDL or non-HDL right from the beginning. ApoB, because of lack of facilities, is usually not estimated in our day-to-day practice. But a good idea about the levels of ApoB can easily be obtained by non-HDL cholesterol. HDL is a fallen angel because all trials of elevation of HDL by pharmacological means have been flop trials, and this is no longer perceived as a modality in dyslipidemia. Then we pass on to the triglycerides. Triglycerides is still in the evaluation, as we will see in the latter half of the lecture. LPA, at the moment there is no evidence-based targets, but now we have PCSK9 inhibitors which decrease LPA by 25%, Inclisran by 80%, and there are several new other molecules which are ongoing, and in future it is expected that we will have trials monitoring LPA levels, and then we may have an evidence-based target. Now, next we will have an overview of the cholesterol metabolism and transport, because you have to have a very clear view of this before we can understand the various lipid therapies. Now, the cholesterol which you take in diet is absorbed from the intestine, as you can see. From the intestine, it goes to the blood. And what is very important to remember is that diet constitutes only 15 to 20% of LDL cholesterol. The major chunk, 75 to 80%, is synthesized in the liver, and as you can see in this slide, this comes back into the liver. The LDL from blood is cleared in the liver by the LDL receptors, and this is the sole pathway for clearance LDL from the blood. Now we have various drugs which can act on all these pathways of cholesterol metabolism. If you want to decrease the intake of cholesterol, you have to select particular items in the food. If you want to decrease the absorption, we have Ezetimibe, we have cholesterol, which increases excretion of bile acids, and we have statins and bempedoic acid, which inhibits the synthesis of cholesterol in the liver. And PCSK9 increases hepatic clearance of the LDL cholesterol through the PCSK9 receptors. And in familial hyperlipidemia, as we'll briefly comment, we have lomapatide and mipomersin for the familial hyper. So you can see, and lastly, we have icospent ethyl, which was also a positive trial in subset of patients who have cardiovascular disease and diabetics at high risk, showed fantastic results, but the mechanism of benefit, it seems, is not through triglyceride-lowering, it seems through some other mechanisms, and that's why we have a question mark. This trial, although originally was done in patients with hypertriglyceridemia with statin, but the mechanism seems to be different, as we'll discuss. Now, these are the drugs which improve CV outcomes: statins, Ezetimibe, PCSK9 monoclonal antibodies, and icospent ethyl, which is an omega-3 fatty acid. Then we have drugs which do not improve outcomes: niacin, fibrates, resins, and the data is available for bempedoic acid, which has been approved by FDA, and evolocumab, which is a monoclonal antibody to NGPLT, has shown exciting results in preliminary trials with familial hypercholesterolemia. Now, statins, as we said, is a panacea for lipid management, and it has multifaceted actions, as you can see on the screen. It improves endothelial function, and it delipidates the plaque, which will be seen on a vascular MRI. You can see the extreme right hand, the plaque is full of lipids, but after statins, the plaque is delipidated. Any modality which delipidates the plaque is going to improve CV outcomes, and statins improve CV outcomes. You can also see lipid delipidation in invasive studies, the near-red infrared spectroscopy. This is data from the yellow trial, and you can see the upper portion, there are more lipids compared to the lower portions. Statins also decrease inflammation, and we know inflammation is an important component of atherosclerosis. They decrease high sensitivity CRP, and this can be seen on a PET CT. This red hot area is the inflamed area in the left vein. Statins also produce calcification of the plaque. If the plaques get delipidated, get calcified, it becomes stable and is less prone for development of plaque rupture in acute coronary event. What is very important to remember, if your patient is on a statin, you should not get a calcium scoring done because it will not be reliable. Calcium in statins increases calcification in the plaque. So this should only be done if the patient has not received statin. Another thing which is not very well disseminated is that statins also decreases thrombogenicity of the blood. We know only 1 out of 10 plaques rupture culminate into an acute coronary event, and it is the thrombogenicity at the time of rupture which is very important determinant of culmination into an acute coronary event. Statins decreases thrombogenicity of the blood, so if the time of plaque rupture you are on statin, your thrombogenicity will be decreased, and the probability of a plaque rupture getting culminated into acute coronary syndrome will be minimized. As you can see on the screen, statins also decrease the synthesis of isoprenoid, which is responsible for the pleiotropic effects in acute coronary syndrome. So statin is a wonderful drug. It has multifaceted actions. And what is still very exciting is you take statins for 5 years and enjoy the legacy effect for the 20 years, as was shown in the Voskov trial. And this is the Voskov data 20 years after the trial was completed. You can see CHD mortality is decreased by 27%, statistically significant. All-cause mortality by 13%, again significant. CAVG or PCI decreased by 19%, significant. Strokes are decreased by 11%, not statistically significant, only a numerical decrease. And heart failure is also decreased by about 31%, which is statistically significant. Now, another thing you must remember is that the separation of curves are also dependent on the dose of statin. Now, these are two landmark trials, the PORES and the Lipid. If you use the conventional dose of statins, here in the PORES study, simvastatin, and in the Lipid is pravastatin, you can very clearly see by the green arrow, the curves start separating only after a lapse of 1.5 years, which means if you take the conventional dose of statins, you will not have any benefit in terms of reduction of coronary events up to 1.5 years. And I think nobody would like to have this. When we look at the data of the primary prevention trials, again, you can see by there, it takes almost 9 months to 12 years for separation of the curve. And this curve separates earlier in primary prevention trial because the plaque burden is less. But if you use high dose intensity, as you can see in these two trials, the TNT trial and the Lipid, TNT is with high dose atorvastatin, compared not with placebo, but with 10 milligram. But despite this, you can see the curves are starting separating very early within few months, and the magnitude of benefit is more. Had it been compared with a placebo, the curves would have started separating earlier. And in the Lipid trial, this is for comparison, you can see the curves start separating after 1.5 years. Likewise, when you use high dose intestine for primary prevention trial, as is shown here in the Jupiter, the curves start separating much earlier. The cardiovascular events are also much less. So for patients of secondary prevention and high risk primary prevention, never say no to high intensity statins. What do we mean by high intensity statin? We have atorva 80 and rosuva 40, and moderate intensity. You can see the list: rosuvastatin 20, atorva 40, and pitastatin, which is not much used, 2 to 4 milligrams. These are the 3 statins available. And for the low intensity, again, we have rosuvastatin 10 and atorva 20, pitavastatin 1. Those statins which are lipophilic, there are more chances of CNS and muscle toxicities, like simvastatin, lovastatin, and atorvastatin, compared to the hydrophilic statins like rosuvastatin. Now, all of us seen the statin era for last 33 years, and statin era has passed on one very, very clear message. That is, they are powered to decrease LDL by 1 millimoles, and this decreases cardiovascular events by almost 22 to 23%, irrespective of the baseline levels. Statins are very safe drugs. As you can see, for every 10,000 treated patients for 5 years at or 40, only 5 cases of myopathy, 50 to 100 cases of new onset diabetes, which usually develop in individuals who are otherwise prone to diabetes, and 5 to 10 hemorrhagic strokes. No cognitive decline. Now, when you are using statin, you should be very careful that if the patient has developed an acute coronary syndrome, if the patient is not a statin, you must immediately start high intensity statin. If the patient is on a moderate or low, immediately increase the dose of statin to high intensity statin. If you withdraw statin, this is associated with increase in the morbidity and mortality, because sudden withdrawal of statin results in increased thrombogenicity of the blood and also impaired endothelial dysfunction. So this should always be remembered, and this is termed as statin discontinuation syndrome. Now, after the statin era, we had the IMPROVE trial where simvastatin has shown, where Ezetimibe on top of moderate intensity simvastatin has shown additional benefit in terms of reduction of cardiovascular events, further proving the hypothesis LDL lower is better. The benefit, however, was carried out only in post-ACS patient, and the diabetic benefited. Now, the second group of molecules, which are again a wonder molecule, are monoclonal antibodies against PCSK9. We have 2 approved molecules, evolocumab and alirocumab, and as you can see on the right upper, they decrease LDL by 50 to 70%. 4 years, the LDL was decreased by 59% at 4 weeks. ApoB, it was decreased with alirocumab by 62% at 6 weeks. And in the ApoB, LDL was decreased by 75% at 4 weeks. PCSK9 are also closely following the footsteps of CTT meta-analysis like statins, and they also produce an additional decrease in cardiovascular events on top of statins by 15 to 20%. Now, these two, the upper 2 molecules are approved. Boxazumab, which was tried in the SPIRE 1 and 2 trial, was prematurely discontinued because this monoclonal antibody was partly human, partly murine, and there were a lot of neutralizing antibodies, and which decreased the efficacy of this drug. So what are the achievements of PCSK9 monoclonal antibodies? They have produced fantastic results. They decrease LDL by 40 to 60% on top of all lipid-lowering therapy. And this reduction in LDL translates into additional benefits in the cardiovascular event. LPA, interestingly, we'll see what additional benefits. Decreases by 25%. All lipid profiles are favorably altered. Very good safety, even up to levels of 10 milligrams, and it produces incremental benefit with no side effects and no diabetogenicity or muscle side effects. Now, when we look at the LDL trials of last quarter of century, there are very big messages. All of us know 4S trial taught us high LDL is bad. The HPS trial taught us average LDL is not good. The TNT taught us lower is better. And the IMPROVE taught us further lowering is still better. And the molecule of the decade, evolocumab and alirocumab, taught us LDL lowest is best, lowest is best. And when we look at all these trials of last quarter of century, there are 2 other big messages which are coming. The first big message is, if your LDL is above 100, lowering of LDL culminates into reduction in mortality. But if you are lowering LDL below 70, if your LDL is above 70 and you're lowering it below this level, this only produces reduction in cardiovascular events and regression of atheroma, but there is no mortality benefit. And this shows the safety of LDL. LDL data from the Fourier trial, LDL was brought down up to 10 milligram, and there were no side effects, and there was incremental benefit. The amount of LDL which is necessary for normal body metabolism is 25, and therefore lowering LDL should not be of any great concern. And what other messages PCSK9 has passed on, that the side effects are not due to lowering of LDL, but due to drugs used for lowering. Statin produces side effects because not of LDL lowering, but because of the molecule. PCSK9 do not produce side effects of statin. So clearly indicating side effects of lowering LDL are not because of lowering LDL per se, they are molecule related. And PCSK9, as we'll see, have greatly impacted current lipid guidelines. The targets for LDL has been slashed down considerably, as you can see in this slide. For the low risk, it is 116. For the moderate risk, 100 milligram LDL. For the high risk, less than 70. And for the very high risk, less than 55. And those patients who are already on a high intensity statin, develop an atherosclerotic cardiovascular event, a new one, the targets can be slashed down even up to 40 milligrams. How does PCSK9 act? I think all of you are quite familiar with this. The normal function of LDL receptor, the curly yellow molecule, is they bind to the LDL, take the LCD inside the liver cells, and the LDL is cleared. The normal function of PCSK9 is it binds to the LDL receptors, as you can see in the lower portion of the slide. The LDL receptor on one hand has the LDL particle, on the other hand has the PCSK9. Now these receptors are taken inside the liver cells, the LDL is cleared, but PCSK9 results in lysosomal degradation of LDL, and it cannot be recycled. The number of LDL receptor decreases, and there's less clearance of cholesterol. On the other hand, if you use a monoclonal antibody, then this monoclonal antibody will not allow PCSK9 to adhere to LDL receptor. The LDL receptor will continue to bind to LDL cholesterol, and it will take it inside the cell and produce clearance of LDL. The number of LDL receptors will increase, and there will be better clearance of the cholesterol. Now, this is the first outcome trial, the Fourier trial, carried out in patients with stable coronary artery disease, stable atherosclerotic coronary disease, and this was shown a statistically significant reduction in the primary endpoint by 15%. The primary endpoint has cardiovascular death, MI, stroke, hospitalization on stable angina, and coronary revascularization, but there was no mortality benefit. The OC outcome was carried out with alirocumab in post-ACS 1 month. This again produced a 15% reduction in the primary endpoint of CHT death, non-fatal MI, fatal or non-fatal ischemic stroke, and unstable angina requiring hospitalization. This also failed to show any mortality benefit, CHD or all-cause. But in the subgroup analysis, the LDL was more than 100, as we talked in the past also, there was a reduction in the all-cause mortality. This is the data from the SPIRE-2 trial, both SPIRE 1 and 2, but prematurely terminated because they were carried out with evolocumab, which produced a lot of neutralizing antibody. But despite this, the SPIRE-2 trial, as you can see, decreased cardiovascular event by 21% within a span of 24 months. And this is the latest EvoPax trial, which is being tried in patients with acute coronary syndrome. The PCSK9 antibodies are administered 24 to 72 hours after, and this is not an outcome trial, but it has produced substantial reduction in the LDL cholesterol. I'm sure outcome trials will also be conducted. Now, familial hypercholesterolemia itself is a very vast topic. We are not going to touch it. And we have dedicated trials with PCSK9 inhibitors, as you can see on the slide, for homozygous, Tesla, and Taussig, and for the heterozygous root 4 or C1 in 2N or CFH. PCSK9 has revolutionized the management of uh, familial hypercholesterolemia. After using statin, ezetimibe, we can now use PCSK9 inhibitors. Otherwise, prior to PCSK9 inhibitors, these patients were subjected to LDL apheresis or very toxic molecules like mepomycin or loperamide. But now the outlook is being improved. Now, this evolocumab is a new molecule. It is an antibody to angiopeptin like 3, that is NGPLT3. And in preliminary trial in homozygous hypercholesteremia, you can see it decreased LDL by 47%. So this is a new approach. This is a short-term study, but I'm sure long-term studies will be conducted. The side effects were negligible. So after PCSK9 inhibitors, we are having another new pathway for lipid management. I'm sure trials will be conducted. Now, statin use is associated with muscle symptoms. In the randomized trial, if you look at the data, myalgia, which means muscle symptoms, normal CPK, 1 to 7% myositis, increased CPK along with muscle symptoms less than 1%, and rhabdomyolysis is usually rare. CPK gets elevated more than 10 times, and there's increase in creatinine and myoglobin. But in the day-to-day practice, the statin muscle symptoms may be seen in say 2 to 25% or so. The lipophilic statins, as we said, are more likely to produce muscle symptoms than the hypophilic statins. And we have now PCSK9 to those patients who cannot tolerate statins, and dedicated trials like GOS and OTC have shown good results. There are several mechanisms of statin-associated muscle symptoms. We are not going to go into the details. If statin muscle symptoms appear, you can try with other statins. You can try with rosuvastatin, alternative twice a week, even once weekly has been tried. Previously, pravastatin was also tried, but this is not available. But in our country, pitavastatin should be preferred. This does not produce muscle symptoms. So this is one indication of pitavastatin, which is usually not available and frequently used, that doesn't increase muscle symptoms. When we look at the diabetic set, all landmark trials of PCSK9 has substantial number of diabetic patients, and they also immensely benefit. Time does not permit to show the individual data of all these trials. So PCSK9 is a new star in lipid management. It decreases LDL by 50 to 70% on top of all lipid-lowering therapy. 70 to 90% patients achieve LDL goals with this molecule. Interestingly, LPA is decreased by 25%. LPA is very common in Indian context. No major side effects except for some minor effects, and it is used for patients of ASCVD, high-risk patients who are not able to achieve the LDL goals, familial hypercholesterolemia, and statin intolerance. A very new data has now appeared with PCSK9 that if you use PCSK9, it decreases venous thromboembolism, and this benefit is usually seen after a year. The left-hand slide, you can see no curves are not separated. This data with the evolocumab from the Korea trial, and after 1 year, the curves start separating, and you can see there is a significant benefit, 29% benefit. Now, this benefit is not related to the lowering of LDL, it is related to LPA. Those patients who have higher LPA level, they are the ones they get benefited. And the reason for this is LPA, besides being atherogenic, is also thrombogenic, and this is the reason why there is decreased VT in patients with PCSK9 inhibitors. This resin colesevelam is also available. It is used particularly in familial hypercholesterolemia when the goals of LDL are not achieved, as an add to anti-diabetic medication, because it is, also decreases blood glucose, and in pregnancy this is also can be used. Now, lomepatide is a molecule. It is an MTTP inhibitor. usually used in patients with familial hypercholesterolemia, not used otherwise because the toxic molecule, it prevents the transfer of triglycerides from ApoB to VLDL, less formation of VLDL, less LDL, and it is associated with side effects, but it decreases LDL by 50% on top of statin. It's a very powerful molecule, but only used in FH. And this is mipomarsin, which is an injectable therapy, which again decreases LDL by 25% and is used in dosage of 200 milligrams subcutaneous weekly. It is an antisense to ApoB, but again, this has a lot of side effects, flu-like syndrome, fever, hepatic steatosis. So these molecules are only reserved for familial hypercholesterolemia. Now, what are the limitations of PCSK9? Now, there are two limitations which have been observed. These monoclonal antibodies require 12 to 26 injections per year, and adverse data is same like PCSK9. So the trial started to search newer and newer molecules and small interfering RNA, which inhibits the synthesis of PCSK9 click. And as we said already, this showed very interesting data. A single injection of 300 milligram decreases LDL by 50%, and this remains there for 6 months. There are several Orient trials, Orient 11, all, and a lot of the head-to-head trials are also ongoing. The outcome trials are also ongoing, and it is emerging as a strong competitor to monoclonal antibodies against PCSK9. And you can see this is all Orient programs. So many Orient trials are ongoing, and there's a lot of excitement in Inclisran. PCSK9 is a new therapeutic innovation. It decreases LDL by 50%, and this remains there for 1 year. Animal data is out, human studies are ongoing, and if the trial comes out to be positive, then booster dose of PCSK9 every year will be the new modality to minimize atherosclerosis. Now, bempedoic acid is another new molecule which has been approved by FDA for lowering LDL, and it acts a stage before the PCSK9, as you can the ATP citrate lysis inhibitor. Statins act at HMG coenzyme reductase inhibitor, and it doesn't produce muscle symptoms, and it decreases LDL by 18 to 20%. This is the clear wisdom trial, same. And if you use in combination with Ezetimibe, 10 milligram this and 80 milligram bempedoic, it decreases LDL by 36%. The last issue is triglycerides. Triglycerides are very complex molecules, and they are still under evaluation. There are lots of ifs and buts with triglycerides. Now, we have very clear data that if your triglycerides levels are elevated, this is associated with increased cardiovascular mortality, all-cause mortality, as you can see on the left side of the screen. And if you have very low triglyceride, as happens in genetic mutation of ApoC3 or PTL4, where you have very low triglyceride level, this is associated with decrease in the cardiovascular events. But the problem is we do not have as yet any positive CV outcome trials of lowering TG on top of statins. The ACCORD LLA was specially designed to test the benefits of fibrates on top of statins, but it failed to show benefit, although the subgroup analysis of TG more than 204 in HDL did show a benefit, but subgroup analyses are only hypothesis generating. It has to be tested in a large randomized trial, which is non-existent at the present state of time. And this is meta-analysis of the 5 fibrate trials. The problem with this is not all trials have been conducted on top of statins, when it is mandatory at the present state of time to conduct all trials, to use fibrates on top of statins. The diabetologists often use fibrates based on this data. REDUCE-IT trial was a very exciting trial, and this was carried out in patients with established cardiovascular disease or diabetics with risk factors. The follow-up trial was 4.9 years, 8,000 patients. Triglycerides in this trial was from 135 to 499, and these patients were on statin therapy. LDL was 41 to 100, and this molecule decreased triglycerides by 39 milligrams. The average TG was 216, and it decreased by 18.3. LDL, there's no sufficient. And this trial showed very exciting results. As you can see, the primary endpoint was decreased by almost 25%, cardiovascular death, non-fatal MI, non-fatal stroke, and coronary revascularization. And this gave a great boost to the triglyceride protein. And they said, now we have this trial. We have shown that if you have hypertriglyceridemia, 135 to 499, you reduce triglycerides and you have a positive CV outcome trial. But and this shows icospent ethyl was used, and you have to be clear about that. This IPE only contains EPA, which is more than 96%. Many trials have been conducted with omega-3 EE, which has a combination of EP and DHA, but most of them have been negative. And we also have omega-3 FFA, which contains EPA and DHA, but different combinations. The secondary endpoint also showed a 26% reduction. But what was very curious, when we analyzed the data based on TG less than 150 more, then the benefit was nearly the same, as you can see here. And when we analyzed the secondary endpoint, the benefit was more in TG less than 150 compared to more than 150, clearly indicating that in this trial, icospent ethyl was used in patients who have high triglyceride, but the mechanism of benefit is not through lowering of triglyceride. It is perhaps because of anti-inflammatory action, antiplatelet action, and so on. So this again created a question mark that reduce-it trial is not really showing benefits due to lowering of triglyceride. The data is excellent. It has been approved by all the guidelines. Every endpoint is to the left. The confidence interval does not cross the midline. So fascinating results. The CT guided trials are also ongoing to see its effect on atherosclerosis, and these are the results. There's some improvement in atherosclerosis. The other molecule is seroglitazar, is made in India molecule. We are very proud of it, and it was approved for diabetic dyslipidemia way back in 2013, and the DCGI approved it for NASH and type 2 diabetes in 2020, and we are very excited. It shows fantastic results in NASH. The fat is cleared up. And when we look at its profile, there is substantial reduction in the triglyceride, more than 50%. Non-HDL again substantially reduced, 21 to 30. Small dense LDL is used. It also improves the glycemic control. Look at HbA1c 0.7 to 1.6%, and the serum enzymes also reduced. But the problem with seroglitazar is there is no CV outcome trial of seroglitazar. We are very hopeful if such a trial comes, then it will be of immense benefit to all of us. So to take the triglyceride issue further, because till date we do not have any positive CV outcome trial which has directly shown you reduce triglyceride, you get the benefit. So other problem with most of the triglyceride fibrate trials is that the triglyceride was near about 200. They did not include patients who have very high triglyceride, like the reduced trial. So we have now the prominent trial with femafibrate 0.2 milligram tablet twice daily in diabetic patients. Look at the triglyceride 200 to 500, and in low HDL, which is the patient commonly encountered in the Indian context, with established ASCVD on top of statin therapy, and we are keenly awaiting the results which are expected in 2020. The STEM trial is also ongoing with omega-3 fatty acids, again a mega trial, 13,000 patients, mixed dyslipidemia, high CV risk, on optimum, and this is not like the reduced trial. Icospent ethyl use only DHA, and this is using a combination of both, and the TG again are 175 to 499 HDL. So these are two common subsets we see in Indian dyslipidemia. We are hopeful the trial may come out positive, and then we will be able to say that yes, triglyceride, lowering of triglycerides improves CV outcome. The question arises as to why all trials of lowering triglycerides do not improve CV outcome. We have trials after trials. Some of the trials are shown. The reason is that the risk of atherosclerosis is related to the number of circulating atherogenic particles, and each atherogenic lipoprotein particle contains a single molecule of ApoB, and therefore the concentration of ApoB provides a direct measure of the number of circulating atherogenic particles. It is the ApoB which enters the vessel wall and not the triglycerides. Increase in triglyceride, no doubt, is associated with increased level of small dense LDL, and these can also enter the vessel wall like the other remnant molecule. But by the time they become small dense particle, they have shed triglycerides and are rich in LDL. So triglycerides, from the point of view of atherosclerosis, is an LDL problem, and statins are the drug of choice. But from the point of view of pancreatitis, you have to treat them with fibrates, omega-3 fatty acids, and cerebrosar. And if you look at the ApoB composition, even in patients with diabetics, very severe hypertriglyceridemia, you can see 90 to 95% of ApoB at any level of triglyceride is constituted by LDL, and that is the reason why LDL and LDL is so important, and it is ApoB which penetrates inside the vessel wall. And look at the Quebec trial. If you are have only hypertriglyceridemia and your ApoB is normal, there's no atherogenic risk. But if your ApoB is elevated and you have hypertriglyceridemia, the risk mounts up, the hazard amount, as you can see. And this is another reason that if you look at the hazard ratio for coronary heart disease across the quintiles of triglycerides, if you look at the unadjusted data, there's an increase in the hazard ratio here, you get 2.5. But if you look at the adjusted data, the curve is horizontal. So what is the summary for triglycerides? Raising of HDL by drugs is a futile strategy at the present state of time, but reducing triglyceride may still have a role in atheroprotection, but triglyceride is still in the search of a positive CV outcome. Trials, and I already told you, 2 trials are ongoing. All guidelines recommend lifestyle modification to treat triglycerides from the atherogenic point of view, and if the triglycerides continue to remain elevated above, say, 135 or 150, icospent ethyl has been recommended by the various guidelines. But if it is more than 500, you can use fibrates, omega-3 fatty acids, and cerebrosar to prevent pancreatitis. And this is ADA 2020, very clearly shows statins plus fibrates is not recommended for diabetics. And this also very clearly shows statins plus niacin is not recommended for HDL elevation or for triglycerides. So in summary, when we look at the lipid management for ASCVD status 2020, what are the big messages? Statins are the backbone of treatment, and they should be the first agents in all patients with dyslipidemia. Ezetimibe can be used as an adjunct to statin if the LDL goals are not achieved. PCSK9 is a new wonder molecule, and the 2 molecules, evolocumab and alirocumab, are the fully humanized monoclonal antibodies, and they made PCSK9 a validated target, and they have evoked a new concept of super low LDL, 25 to 50, never heard before. They produce incremental benefit with incredible safety, and they're also useful in diabetics. They are user friendly for diabetics. Inclisran has shown very exciting data and is emerging as a competitor to PCSK9 monoclonal antibodies. PCSK9 vaccine is a new therapeutic innovation for futuristic trial. Reduces trial has shown fantastic results. And evolocumab is a new therapeutic innovation, which is an ANGPTL3 antibody, and preliminary data showed a new pathway for management of homozygous hyperlipidemia. So we are amidst a new world of drugs for dyslipidemia, and dyslipidemia has become a very, very exciting topic. Bempedoic acid is also added to the therapeutic armamentarium. Thank you very much.